Yeah, Sengottuvelu. Sengat, I'm Dr. Srinivas Kumar here. Can you hear us?
Good afternoon, Dr. Srinivas.
Yeah.
We can hear you. Can you see us also?
Yeah, we can see you. Over next 20 minutes, we can show important steps of the procedure. Is Dr. Saibal also with you there?
Okay. See, we are all excited because we are doing a mitral clip case today. We have a workshop. Saibal, we have just finished the first mitral clip case.
Okay.
And Saibal is just going to start the second case, so he just can't come on live. But we are going to show you the first case, and then we also have done a pulmonary valve with a pulmonary valve with using a my valve. So maybe I can show you that for quickly, and also the mitral clip case which we have just done. Srinivas, can you hear us?
Yeah, we can hear you well and see you well. Go ahead. Hello?
Okay, so we'll start. We did this pulmonary valve. I'm going to show you this quickly and then followed by the mitral clip what we did. This case was done last week. And see, this was Dr. Muthu is my colleague who is here with me, and we work as a team. And this is Muthu, you can just present this case.
So good afternoon to everybody. I'm Dr. Muthu Kumaran. This is a 26-year-old presented to us with history of breathlessness and exertion, and she's a tetralogy of fellow, operated at 5 years of age, and she developed RVOT obstruction, for which a surgical pulmonary valve replacement was done at 16 years of age, and she developed mediastinitis with infected endocarditis following the surgery. We tried to treat her with antibiotics, but the infection could not clear, so we removed the vegetation and the valve at 17 years of age, and we implanted the Cantagra valve at that time. So, and she was under follow-up at the time, and she was noted as severe RV obstruction with RV dysfunction. At 24 years of age, I saw her, and then we stented the RVOT with the 45 mm CP stent over 20mm valve, 20mm balloon, and the pressure decreased well, and she was fine after that. At the time, we had difficulty in acquiring a valve which is cost effectively because the valve expenses were 27 to 30 lakhs at the time in 2017. So she did present after that mild breathlessness, and she expressed her idea of getting married, and she had a free PR. So we did discuss the surgical team as high risk because of her mediastinitis and 3 surgeries so far. She was referred for transpulmonary valve implantation. We did angiogram, and we found out to have a free pulmonary regurgitation, and also the eye pressure was normal. So at the time we did had some experience using my valve in the aortic position. So we felt that we could use the same valve as Edward Sapiens valve. We can do it in the pulmonary position also. We did a CT scan which showed that the annulus measured 20 mm, the valve, the stent. So we are using 23 valve. So we access the femoral vein. The only access we got is femoral vein only, and artery line to monitor the blood pressure. Next, after that, we went inside. So we did angiogram first. You can see this is the PA angiogram. You can see the stented RVOT. There was no obstruction, and you can see there's a free pulmonary regurgitation happening. So we crossed the stent, and we took a balloon across because we have to make sure the coronaries won't be obstructed when we inflate the balloon. So we did a trial occlusion.
And in fact, it's very important to make sure it doesn't go through the strut. Initially, we couldn't get the balloon across. So then we realized it's probably gone through the struts of the stent. And then instead of pushing the balloon, I think we took it and put it wire back again. And simultaneously, we're doing a right coronary angiogram to make sure there is no obstruction.
So you can see here the catheter in the right coronary. There is no obstruction to the right coronary. There is no anomalous left origin. If it's there, then we have to engage the left also, do a balloon dilatation. So after this confirmation, what we thought is we should dilate it further to 20 mm. So we took a Atlas balloon, for high pressure balloon, making sure that we can expand it nicely. So the Atlas balloon was taken across. It's quite a tough balloon. So we finally inflated to the maximum of 20 mm, so that we can put 23 valve. So you can see the Atlas balloon opening. Now again you can see here. So after the Atlas balloon is open, then we took the Atlas balloon off and we took the Python sheet. This is a custom made by the MyVal team. It's a expandable sheet actually.
I think you just heard about it in your discussion. I think
so. We took the Python sheet, and then after that, the important point in a pulmonary implantation, you can see the wire nicely anchored above the left diaphragm. You can see that there. That's what the position should be. If you don't have a proper wire position, your valve cannot be pushed inside. So we took the valve, you can see valve coming across.
So with the Lundquist wire, I think the valve went quite smoothly in.
So after that positioning of the valve, we made sure that we are at exactly the center of the center point of the stent. Then we inflated the balloon. We didn't pace the heart because the IV pressure is not so high. So we didn't pace the heart. So the inflation will be done now. You can see balloon coming up. Slight movement of the balloon is there. So at this point, second operator should hold the balloon in position with a backward pressure, so that the stent doesn't move in front. So we inflated the valve to the maximum of the measured volume. Then we deflated the balloon. We took the delivery system out. So post-procedure angio showed no PR, there's no grain duct of the pulmonary valve. The lady went home the next day. And that's the next picture showing good position of the pulmonary valve with no obstruction and no regurgitation. So this demonstrates the use of MyValve in pulmonary valve position, and it is particularly useful in patients who have mild to moderate stenosis. The maximum RVOT diameter we can stent across is 26-27 mm, and if you have a wide open RVOT, it's still a challenge, but this can be used from 23 to 29 mm valves available, so we can use up to 26 mm RVOT.
So actually this is the first time MyValve is being used in pulmonary position. And since it was already stented, it was a very suitable patient. And we actually thought of using a 20 millimeter valve, but then we used Atlas balloon and we little oversized, and we got a great result with the 23 valve. So you would like to have a quick discussion and then we move on to a might clip case, Srinivas?
Sangat, we are actually left with only 10 minutes because they're supposed to screen this place and we are supposed to vacate. Please go and present the next case.
Okay. We'll go ahead with the mitral clip. This is the patient we did in the morning. Just now we know that due to regulatory approval, we cannot go live. Actually, Dr. Srinivas was wanting to do this live, but I think it not be possible to do live because of the regulatory approval. This is a 79-year-old gentleman, known hypertensive, and he had presented with class 3 symptoms for the past 2 months with occasional episodes of PND, and he didn't have coronary arteries were normal. And this was his echo, and echo shows a severe MR. You can see the P2 flail.
It's a biplane view. Normally we get in this in the Philips Epic. You can see that the valve is flail. The posterior leaflet is flail in this position. You can see there's a flail leaflet here. An anterior leaflet is fine, but you can see a A2 P2 component. P2 is prolapsing over the A2. So this is very important to demonstrate which exact position we are having a leak. The three-dimensional echocardiography helps you to demonstrate that. Basically, this technique is done in mainly in echo guidance and also some fluoro guidance. So here if you see that, this is a point where we have to go with the mitral clip and hold the flail segment and the A2 so that the leak can be arrested. Go next.
Make the echo bigger, please. Yeah, make the echo screen bigger so that they can see better.
So the LVOT view we can see here in this position. This is another view, this important view, LVOT view. Then when we get a LVOT view, we go exactly perpendicular to it by explain and show the other view also. And you can see there is a flail segment, and you can see the anti-mitral leaflet and the posterior mitral leaflet P2 component prolapsing over it. Next.
So clearly this patient with the elderly patient with severe MR, we discussed the options and discussed with the surgeons as well. And with the patient preference, we decided that the patient should undergo a mitral clip. And the anatomy was very much suitable. And at the moment, we have problems with the regulatory approval, so we had to get the license and wait for the approval and then import the device. And we did the case today with after all the approvals, and you can see this is the TE which we started with. We can see the severe MR. I think I'll go step by step and the procedure, and this is the bicaval view. You can see the septum, and this is the view to explain where to puncture, and we are just getting ready to puncture. So we can see that we are taking the sheath in.
The most important step is the puncture. Actually, you took a lot of time to puncture this actually.
Yeah.
So you have to be at the fossa ovalis, very posterior part. One more important thing is your puncture point should be around 4.5 centimeter from the annulus of
Yeah.
your mitral valve,
Yeah.
so that you can position exactly. So it took about at least 20 minutes for us to really do puncture, and we did try a few positions. We moved around and we made sure we are posterior part of the fossa ovalis and made sure we punctured it, and we did with only echo guidance.
So you can see that we don't have a pigtail for in the aorta, so we just had just one venous puncture, and just with TE guidance. And we also put a pre-closure with the ProGlide for the venous in a 24 French sheath. So we put a one ProGlide at 12 o'clock position, and so you could see this now. You can see the bicaval view. You can see the tenting of the septum. It's in the center. And making sure that it's the right position. You can see we are just making the puncture. And once the puncture is done, we are sliding the dilator and then the sheath inside. You can see that in the left atrium. So once it's done, then we take the guiding catheter, which is taken in. And what Dr. Saibal wanted to do is to keep two wires so that we can put a pigtail and monitor the pulmonary venous pressure. So we can see two wires. One is a regular wire with a pigtail. The other is a Amplatz extra super stiff wire, and this is to track the device. So once we do that, now we are advancing the pigtail. Now the pigtail is in the pulmonary vein, and then we now take the device.
Sheath.
This is the sheath. This is actually the guiding catheter, and the guiding catheter is you have to reduce the angulation, the initial step. Otherwise, it can cause injury to the IVC. So we have to reduce the angulation here. We have to reduce. You can go more negative. We can make it more straight. And then you advance it into the septum, and you can see the marker. There is a marker at the tip of the guiding catheter. And then the dilator is removed, and we take the clip delivery system. And this is the clip delivery system which is taken in, and making sure we aspirate and making sure there is no air entering into the system. And there's a clip which is being taken inside. We monitor this by echocardiogram simultaneously. And then we move it again, adjusting both the medial. There is two knobs, anterior posterior knob and the medial lateral knob. We can move the entire clip delivery system by moving these knobs and making sure these clip delivery system is not close to any of the walls, can cause injury, and also making sure that it is coaxially entering into the mitral valve apparatus. So again, you can look at the echo.
So here the echo, actually the very important thing you can see that in this view, there's a co-septal view. We can see that the LVOT view and the perpendicular view, where we have to make sure that we exactly opposing the leaflets, and your cone of the clip faces the leaflets. So if you have, and also it should be in a position where it's parallel to the way the valves are opening, because if you do other way around, it can't hold the valve leaflets. Once we are certain, then we do some pulling movements of this clip, so that we make sure that we are entering the LV in the right position, in right direction. Once we know that we are across it, then we push the system.
So the transmission, torque transmission is extremely slow. So if you want to make a clockwise rotation, it takes time. So we sometimes do a to and fro motion so that the torque gets transmitted. So it takes some time. And
now you can see that the clip has been nicely positioned in a way it's going to hold the leaflets. If it's the other way around, it won't hold leaflets. So we have to look at two views here. We do a 2D biplane explain view, and also we go for a 3-dimensional NFAS view, so that we make sure that the clip is exactly in a position where it's going to hold up the leaflets. Next page, next time.
So the leaflet is grasped, and then we can check whether we are grasping the right leaflets to check the MR. And
We can see that we are exactly a position to the MR jet. This it guides you exactly where the pathology is. So this is where we have to hold the leaflets. So if you are quite away from it, the two movements you can do, either you can go lateral or medial, so that you can move your entire system up and down. So make sure you have to make sure the exact center of the jet, so the pathology is being addressed properly.
so here we are just exactly at the center, so we probably could manage with one clip if it effectively seals the MR.
Now what happened? Now we have pushed the clip inside. You can see the clip is open nicely, and now we know that the leaflets are touching the both wings of that. You can see nice wings of the clips. So we know that position where we can grab, and also the jet is exactly the same point where the clip is. So we assessed in different views. It took a lot of time to look at where we exactly going to do that.
Again, we have to make sure that both the arms of the clip are having equal distance in that view, and it looks like a straight line in the other view. So making sure it is aligned properly.
Now you can see that we are going to grasp this. We have already got the leaflets, anti-leaflet and the post-leaflet. You can see anti-leaflet nicely inside the gripper, and also here you can see post-leaflet inside gripper. We haven't closed the mitral valve clip yet. We just lower down the gripper so that it's just holding up the leaflets. Now in this position, we know that we are going to grip the leaflets. Next.
So this is again what we saw in the echo. We can see that we are moving the clip down.
Now we're closing the clip.
We are just going. Yeah, we are there.
Now we close the clips. Now you can see the clips have been closed in this view to a LVOT view and the perpendicular view to that. So you can see the leaflets.
Yeah.
One of the important things you have to make sure here, it took a lot of time, is you can see a buckling of the leaflets here. It means the leaflet has been held properly. Both sides you have to make sure the buckling happens. If it doesn't happen like this, it means that the leaflet hasn't been held. Then you have to release the clip and do it again.
And grasp the other. Yeah. So this is now we are satisfied with the position. We are looking at the MR now. See, with that we could see the MR has greatly come down.
We did even increase the pressure to 180, 190 at this point to make sure there is MR happens, because you know if even the blood pressure goes up, there was no significant trivial MR was there, and we thoroughly checked up with all the views, and we are making sure the leaflet is caught.
We had a pigtail in the LA, so we could monitor the V wave and the pressures, pulmonary venous pressure. We can significant reduction in the pressure once the clip was holding the valve properly. Then we decided that it's a good position, and then we can release the clip. So now this is the clip release, which you can see on this side. And once the clip is released, the next important steps are, we could see that significant reduction in MR, making sure the device is taken out without causing any injury. So it is again important to take it out slowly with the echo guidance. And this has been out into the guiding, and then the guiding is removed. And this is the echo. You can see this is the post deployment. You can see the double orifice in the mitral valve. There is no significant, very trivial mitral regurgitation. And this patient had a gradient of 2 millimeters. So it was a great result for this patient. And what was very interesting is not even 1 ml of contrast was injected, and just one venous line, and it was again using a perclose. We closed the venous line and obtained hemostasis. And it was a general anesthesia, short GA. We extubated the patient immediately after the procedure. And the patient is now moved to the ICCU and doing very well. And thanks to Saibal, I think he was so keen to start the program in India. And without his help, I think he wouldn't have got this device to India. So this patient greatly benefited from this procedure. And Srinivas, would you like to have some questions? Or?
Any comments from you, chairs?
Congratulations on a very well-done case. You're learning from the master.
The chat Rihal here. Can you hear?
Yes,
Sangat?
hello. Well, yes, congratulations on a very well.
Yeah, we can.
You're learning
Thank
from the master with Saibal Kar.
Yeah.
And
Thank you.
I think he made a very complex procedure look easy. So just keep that in mind. There's
Exactly.
many pitfalls in this procedure, and every step has to be carefully thought out and carefully executed. Every one of those has tremendous pitfalls, so congratulations.
Thank you. Muthu, congratulations. Like, if you have a RVOT standing, which is a covered stand, is self-expanding. The retention power of the pulmonary valve will be much stronger with self-expanding exposed base stand other than a smooth covered stand like CP. That is one comment. About, Sengottuvelu, the mitral valve clip, if you want to place two clips, would you go for exterior first, then anterior, two exterior, or anterior versus exterior? It did not show any 3D images. I'm sure it is anterior. So suppose you want to put two clips, you start with exterior, then the second clip will be anterior, two anterior or two exterior.
Actually, that can be taken later because anyway, Saibal is not here. We are just learning our techniques of percutaneous mitral procedure. But the comment on pulmonary valve, you can take it. Go on. You want to answer the pulmonary valve
the
question?
self-expanding and I
you
guess
go
what he
ahead.
says is you can use a
Look at the mic.
self-expanding instead of
Look
a
at the
balloon
camera.
expanding here. I think that there's a lot of calcium here. If you want to use it in a expanded RVOT, like 30 to 35 mm, where we use a venous A valve, which is a self-expanding valve. But here there's a lot of calcium, lot of hard material there, and so if you use a self-expanding one, it won't expand properly. So you need a lot of force. You even can see that Atlas balloon could not open the entire RVOT clearly. So here we use a balloon expanding valve. In situations where you have a wide open RVOT, we use a self-expanding valve.
Maybe I can answer your question that you asked. If you're in the center of the valve, A2, P2, use the XTR. If you're more in the commissures, use the NTR. If you put an XTR in the commissures, you will get tangled in the chordae. It can be extremely difficult to get out. I've had some bad experiences.
I'm sorry for the interruption, Mr. Chairman. We have totally run out of time for this session. We'd like to thank Dr. Sengottuvelu and team from Chennai for joining us for the live inbox case, and we'd like to thank the chairpersons.
Thank
and
you
the
very much. I
speakers
congratulate Srinivas for
you.
giving us this opportunity. Thank you again. Thank you very much.
Thank you.